Good. So, my name is Professor Young. I teach the Wednesday afternoon and evening classes if we have not met. Um, it's good to have all of you. I love seeing new faces and meeting new people. So, what my plan is for tonight, depending on how many students we get, I always like to do like a review Kahoot game and let you guys kind of practice, do some practice problems. And then at the end, we will open up the floor, so to say, the Zoom meeting room, to any questions that you guys have about the material specifically, anything that you want me to review with you more specifically, or anything just in general that you want to talk about or discuss. So we will go ahead and I'm going to pull up that Kahoot. It's an exam review, exam two review. Has everyone played Kahoot before?
I haven't.
Yes. Okay, so I will show you guys how to, for those who have not, I will show you guys how to pull it up in your browser and how to join. And then once all of you guys are in, we'll just go ahead and get started. I believe it's almost like 17 to 20 questions, so that should give us a good starting point. And then we'll go from there. Okay, so let me go ahead and get this pulled up. Alrighty. Okay, for anyone who just joined, we are going to be playing Kahoot for my review. So if anyone, whoever has not joined before, all you're going to do is take your phone or a tablet. It's easier on your cell phone and either scan this QR code up here or just type in your search bar www.kahootit.it, kahoot.it, and then you're going to put in this game pin and it should allow you to join in on the session.
Okay.
I'm sorry, I just got home from class and I was starving.
No, you're fine. Do what you got to do. I was just snacking on some strawberries anyways.
This way.
Okie dokie. Let me go ahead and switch my Wi-Fi really quick because I think my connection's kind of bad. So hold on, give me 2 seconds. Okay, we'll see if this works a little bit better. Hmm. Okay. Can everyone hear me and see me okay? My connection was kind of weird there for a second.
Yes.
Yes.
Okay. So let's go ahead
Yes.
and get started. It looks like everybody, one, two, three, four. It looks like we have everybody. So we're going to go ahead and get started here, okay?
Let's see.
Yes, awesome. So if a patient starts complaining of a headache and blurred vision, that should indicate to you that their preeclampsia or their symptoms are worsening, okay? All of the other things here, blood pressure reading at baseline, dependent edema has resolved, urinary output has increased, would indicate that their preeclampsia is improving, that their symptoms are getting better, right? Because we know with preeclampsia, a patient is going to start to hold urine, so they're not going to be putting having any urine output or very very minimal urine output. Their blood pressures tends to be pretty elevated, severe range, so that 160 over 110 is what we typically see, but high blood pressure in general is something we'd see with preeclampsia. And then they're going to have some edema or some swelling in their lower legs, their face. It can be generalized. Okay, so yeah, you guys all got that one. Awesome job. So this one you guys are kind of torn on. So whenever we're talking about things that can put a patient at risk for a postpartum hemorrhage, um, we want to think about it as far as like the labor process, what's happening while the woman is laboring, and could potentially lead to some complications with that. So precipitous birth is a huge risk for postpartum hemorrhage because precipitous birth means that that woman, their labor has lasted less than usually 4 hours. Okay, it's very, very fast. So when that uterus is working overtime, our uterus is going very quickly and doing a lot of work in a very short amount of time, that muscle is going to give out and it's going to be a lot more tired in the postpartum period, right? Because it used up all the energy. It was, I mean, it's like any muscle in your body. If you're overusing it, it's going to get tired. It's not going to be able to contract and perform as well. So, in a precipitous delivery, we're worried about that mom bleeding so much because that uterus is so tired after working so hard to get that baby out in such a short amount of time. With gestational hypertension, the only reason that one of the things that I'm sure you guys were probably thinking about is if this patient for some reason was on magnesium, which we aren't necessarily using for gestational hypertension, we're using that to prevent seizures, right? Magnesium can increase a woman's risk of a postpartum hemorrhage following delivery, but just because they have gestational hypertension does not necessarily mean they're at a higher risk for bleeding excessively after delivery. Okay. Um, the two vessel umbilical cord, that one we're not really worried too much about hemorrhaging. We're just worried about the like the anatomy of the placenta and how baby is going to do during labor, right? If they have a short cord or if they have a small vessel cord or a two vessel cord, we're more worried about like placental sufficiency and baby being well oxygenated. Okay. Awesome. So this would be painless vaginal bleeding. So for the purposes of exam two, you guys should know the signs and symptoms of associated with the placenta previa versus a placental abruption, versus like your preeclampsia. Just like know the things that we're associating with each condition. So for a placenta previa, we oftentimes see these women who come in with the painless bright red vaginal bleeding because that placenta is right over the cervical os. So that placenta sometimes starts to shed the lining of the endometrial layer, starts to break away if it is a placenta previa, and you can have some reoccurring bleeding or some spotting. The firm, rigid abdomen would be your placental abruption. Okay. For uterine hypertonicity, that would be like your uterus is contracting too frequently, um, or just has really, really strong tone, which in this case, it's a little bit vague because that could indicate, like, okay, you're having that firm, rigid abdomen. It could be indicative of a placental abruption, or it could be referring to, like, on your fetal heart rate tracing, you just are having too many contractions. Okay. But this one definitely, after for a placenta previa, we're going to see that painless vaginal bleeding. Yes, we would need to have an emergent delivery of the fetus if this was a placental abruption. Okay. If a patient is abrupting and her placenta is coming off of the uterine wall or the uterine or the endometrial lining, it's starting to split away. That is going to reduce the oxygenation to our baby. So if that placenta is being delivered, it's coming off, it's peeling apart, peeling off the wall, then we need to deliver this baby emergently. Typically, patients that have a placental abruption get rushed back to the OR for a stat C-section. It's definitely an OB emergency. Yes, in our second and third trimester, patients oftentimes need to have an increased amount of insulin because their body is more insulin resistant in this phase of pregnancy. In the earlier stages of pregnancy, they may not need as much insulin. Sometimes it also can be decreased depending on the patient and what their endocrinologist recommends. But in the second half of pregnancy, their insulin requirement is going to increase because we're accounting for weight gain with the baby. Baby is going to be needing blood sugar, and they're going to have their own system that's going to be needed regulated as well on top of mom's. So we're increasing our insulin requirement. Yeah, we're going to need our calcium gluconate. Awesome. Everybody got that. That is the reversal agent for magnesium. Anytime you're administering that medication, you should have this at the bedside if a patient starts to show signs and symptoms of magnesium toxicity. For the purpose of your exam, you guys should definitely know signs and symptoms of magnesium toxicity for sure. Can anybody tell me what those would be?
Respiratory depression.
Severe respiratory depression.
Absent deep tendon reflexes.
Yep.
Low urine output.
Yep.
Patient being really lethargic.
Yeah. Sometimes these patients may lose consciousness. They may not be responsive. Definitely. Yeah. You guys hit the big ones. The biggest one, too, for sure to remember is that severe respiratory depression. Those patients are going to go from being alert and oriented times four to possibly lethargic, if not unconscious. So if they start to show any signs of of mag toxicity, we're going to need to administer that calcium gluconate. We're going to stop our magnesium and we're going to initiate a rapid response. Awesome, you guys all got that. If a patient says that my vision for the past 2 days has been really fuzzy, that should be an indicator that their blood pressure is getting worse and that their gestational hypertension is worsening. Yes, anytime there is like potentially blunt trauma involved, we should be worried about a placental abruption, okay? With the placenta previa, a patient being in a motor vehicle accident isn't going to necessarily cause that. A previa is something that will develop early on in the pregnancy as the placenta is developing. Placental abruption is typically caused by like blunt force trauma, another type of incident that may occur. A common thing that we'll see sometimes in the hospital setting is if a woman is using cocaine during her pregnancy, cocaine can cause a placental abruption. So it's mostly caused by outside forces or outside trauma. So for a motor vehicle accident, we definitely are going to want to monitor this patient for typically, I think it's like 4 hours. These women are being monitored on the floor, sometimes even longer, depending on what's going on. Okay, so if we have a patient who has a premature rupture of membranes and she's 37 weeks, Um, one of the things that we are going to question, right, that we are going to not want to do is perform a vaginal examination every shift. And that would be because we do not want to expose her to the risk of infection. Okay. If that bag of water has ruptured, that means that there's no barrier that's separating that vaginal canal from the baby and being in utero. So we want to limit the amount of vaginal examinations we're performing to limit the amount of bacteria that could potentially be introduced to the fetus and to the uterus. With monitoring our fetal heart rate continuously, that is something that we definitely are going to want to do if this patient's water has been ruptured. Okay. Anytime a water has been ruptured on the floor, providers typically want these babies to be monitored continuously because they can indicate whether or not they're showing signs of infection, if there's signs and symptoms of fetal distress, decreased oxygenation. So, monitoring a fetal heart rate is always something we're going to want to do, especially in this case when it's like a kind of a early on the brink of being preterm patient who's ruptured early. Okay. The biggest thing with these patients is preventing infection. So we're definitely going to want to administer antibiotics. We're going to want to continuously get temperatures. Most likely, the provider is going to want you to get their temperature every hour after the rupture just to make sure that if there is an infection developing, we catch it very quickly. So that whenever we're doing a fundal massage or a fundal assessment, our fundus should be firm, it should be midline, and it should be either like right below the umbilicus or at the belly button, depending on how far out from delivery we are. If you are assessing this fundus and you note that it feels soft and boggy, we need to massage until it feels firm, okay? We do not want to excessively push on the uterus to expel clots. Because if you're just pushing on the uterus rather than like rubbing and massaging it, you run the risk of causing a uterine inversion. And that's a big deal. Okay. So we never want to push super hard on the uterus like that. We want to be massaging the fundus until it firms up. Typically, with your fundal massage, you are going to be expelling clots. That usually comes with it. But I think the key term in this one is just avoiding the word push because we don't want to cause a uterine inversion.
Before you move to the next, oh, never mind. Oh. Before you move to the next question, what is the fundus is supposed to be midline and firm, you said?
Yes, your fundus or the patient's fundus should be midline and it should be very firm. You should be able to feel with the top of one of your hands the top of that patient's fundus, and then as you're massaging, you're going to support the fundus with your other hand and provide the continual massaging motion.
Okay.
Okay. Does anyone else have any other questions about this one? Alrighty. Yes, so these are clinical findings of chorioamnionitis. So, chorioamnionitis is an infection of the amniotic fluid. It's an infection that can form around the baby while the baby is still in utero. So, whenever you see like a premature, preterm rupture of membranes, you should be thinking that this patient is at a very increased risk for developing infection. Okay. Group B strep is something that can develop just in any normal pregnancy. That is a bacteria that most women have in the vaginal and rectal tracts that we test for around 35 weeks of gestation. Um, and typically, if a patient has group B strep, they don't really have like signs or symptoms of it. They're not experiencing any like adverse reaction from it. It's just something that is already in the vaginal and rectal tract that's just at a higher amount in certain pregnancies. Group B strep is mostly screened for the well-being of our newborn. It does not affect the mom at all in the slightest. So for this one, if you see fetal tachycardia, so that baby's heart rate is really high, and you see a mom had a temp and her heart rate is really elevated, we should be worried about choreo because that is an infection that can affect both the mom and the baby. Okay. Awesome. Yeah. Deep tendon reflexes, our respiratory status and level of consciousness is going to be what we use to assess for mag toxicity. If you're the bedside nurse, um, taking care of a patient with who's getting magnesium administered, typically you're doing a focus assessment every 5 minutes while they're doing that initial bolus dose. Okay. So in that assessment, in that focus assessment, you're going to be watching their respiratory status, getting all their vitals. You're going to be potentially listening to their lung sounds, doing the deep tendon reflexes, and asking them and making sure that they're still ANO times 4. Okay. So, yeah, you guys all got that. Oh, yeah, what's that, Taylor?
What was Clonus again? What does that mean?
So, Clonus, I need to I need to show a video because I feel like it's way easier to see it. Um, Let me see if I can find one really quick. Hold on, I'm going to stop my screen share first. Just a second here. So anytime we're assessing for clonus, it's typically done on the lower extremities. So we're going to be using mostly the feet. And it's basically assessing for any like extra movements. If you have a patient push down on your hands, they should be just continuously pushing down. They shouldn't have like jerking movements or anything that could potentially indicate that they're hyperreflexic. Okay. So clonus is mostly another way that we can assess like reflexes. So if a patient was hyperreflexic, that can sometimes indicate um, that either like the magnesium is not as effective for this patient and we may need to increase that dose. If they're hyporeflexic, that could mean that their magnesium is a little bit too high, right? Because magnesium is a depressant. So magnesium is going to cause all of the muscles, everything to kind of relax. So you think they're going to have less tone. So that's why this patient could potentially be a fall risk. So clonus is another way to assess a patient's reflexes and whether or not they're hyperreflexive. I do have a video. If you guys want, I can send it in the chat that kind of goes through how you do a clonus assessment. So let me copy that for you here.
So would that be a magnesium like adverse effect or just?
So that would be something that a patient could present with whenever they are like have high blood pressure, whenever they are preeclamptic, and then an absence of clonus or like really decreased reflexes is going to be a symptom of magnesium toxicity.
Okay.
Let me copy this here for you. Okay, so I like this video. It kind of takes you through everything. So if you guys want to watch this, this is a really good review for Clonus. To kind of be able to see what the assessment looks like. I think that's a little bit more helpful than reading about it or me trying to describe it because it is like um, a hands-on assessment tool. Okay. Other ways that we're going to assess for deep tendon reflexes is you would just use that reflex hammer and you would just like be hitting underneath like, you know, in the like the funny bone area on their elbow, on their knees to see like their reflexes with their legs like that. But Clonus is one that you can use if like, you know, just as an additional assessment tool. Okay. Does anyone have any other questions about that? That was a really good question. Okay, awesome. All right, let me share my screen again. Okay, so I think the first question we need to ask ourselves when we're reading this one, what does amniotomy mean?
That's where they're going to rupture the membrane.
Yeah. Uh, yeah, awesome, Tracy. Yeah, that is when a provider is going to go in with an amni hook and artificially rupture a pregnant woman's or a laboring woman's water or membranes. Okay, so that is the fancy term for just a provider going in and breaking a woman's water is an amniotomy. So for your exam, guys, definitely know the terminology because you guys will, it'll be so much easier to answer the question if you know what everything means. Okay, so if we're looking at this and we know, okay, a provider's going to go in, they're going to break water, the baby's at -2 station. What are we thinking about that baby? Where is that baby?
On the canal, on the way to get out. So you know, check the heart rate to make sure they don't get depressed on the.
So we're going to want to monitor their heart rate. We're going to want to monitor it for a different reason though. So if you see a baby is -2 station, are they like very well engaged in that woman's pelvis yet?
No.
No.
They're not, no, because we know at 0 station that that baby's head is just then at the ischial spines of that mom's pelvis. So that baby is still kind of just floating up there. So if you have a baby whose head is not super well applied to the cervix and their head is not engaged in the pelvis and they're just kind of floating around in fluid, you run the risk of that umbilical cord that's also floating around in all of that fluid coming down out before that baby's head. Okay? So that is why we are so concerned with this question, looking at it as, okay, this baby is -2 station because this baby is not down in the in the pelvic inlet yet. And we run the risk of that umbilical cord coming out with all that fluid and having a cord prolapse. Okay. So, for these answer choices, less pressure on the cervix is not wrong because that baby's head is not down on the cervix yet. If they're -2 station, they're pretty high up. However, we're not worried about that as the priority. Decreased number of contractions, we don't really care right now because that doesn't have anything really to do with the question. Decreased effectiveness of contractions, maybe. We're still with contractions and with rupturing water, we're not too worried about it in the way this question's formatted. We definitely need to frequently monitor our fetal heart rate to detect for a prolapse cord. what is our heart rate going to do if there's a cord prolapse?
Would it increase?
It's going to decrease.
Decrease. Okay.
So let's think about it from an anatomy standpoint. That umbilical cord, it is directly going to help us transfer oxygen to our baby, right, from the placenta. So if we have an umbilical cord that is introduced to air, right, it's going to be losing the effectiveness of delivering oxygen in utero because the body system is going to be all confused, like, okay, part of this is delivered. You know, we've technically delivered part of this umbilical cord. So that's going to cause all of the components to shift. So there's going to be less oxygen being delivered to baby. Baby is going to have decreased oxygenation. There's going to be some issues with the placenta as a result. So that baby's heart rate is going to drop big time. In the times that I have seen a cord prolapse, that baby's heart rate will go from just your baseline, like 140, and it will drop to 50 beats per minute, and it will not increase. The other thing we have to think about is if that umbilical cord is delivered first, and then your baby's head comes, and that baby's head is squishing down on the umbilical cord, we have cord compression, right? Which is something that can cause fetal decelerations. So what are we doing? What is our primary intervention as the bedside nurse if we have a cord prolapse? What is our number one focus?
Just getting the baby out.
Getting that baby out, yeah. But if you're at the bedside and you need to immediately increase oxygenation to that baby, what are you going to do?
Put them on the
You're going to put that mom.
You're gonna remove the
Yes.
fetal part off the cord.
Yes, you need to move that mom into a different position, and then you need to put your fingers in, and you need to physically lift that head, butt, whatever it may be, off of the umbilical cord. That's going to increase our oxygenation to our baby, and it's going to help increase our baby's heart rate and get them back to a point where they're stable. This does not mean that this patient is going to deliver vaginally. This patient is going back for a stat C-section. As soon as there's a cord prolapse, we're not going to mess around with delivering vaginally. We need to get this baby out. Okay? Does this make sense to you guys? Because I feel like this is a really good topic to understand for your exam, for sure.
Yeah, you explained it very well because I didn't really understand it.
Well, thank you. I appreciate it. I'm just here to try and make your guys' life easier.
As long as the water hasn't broke or they haven't done the amniotomy thing, we can go in ourselves. Like if we knew for sure it was prolapsed.
So you are not going to have a cord prolapse if your water is not ruptured.
But any other time, like we can't, I guess what I'm saying is the only time we can't go in freely is if the water was ruptured. Brain sac, when you said.
I'm sorry, I think I'm having a hard time understanding your question. Go ahead and ask me again. I'm sorry.
I was trying to think, it was a question on here. Something about the membrane sac, we couldn't do a vaginal exam.
To like limit the amount of exposure.
Yeah, is that the only time for this one you said we could go in and move the baby? So the membrane is the only time we couldn't freely go in, I guess is what I'm asking.
So the risk of infection is very much decreased if a woman's water has not broken yet, because there's still that protective barrier separating the baby from the vaginal canal. So you can go in if a patient hasn't been ruptured and they are okay with it and they are at an appropriate gestation, you realistically can perform a vaginal exam as much as you want or as much as there's indication for. The only times we want to be cautious with when we are doing a vaginal exam is if the woman's water has been ruptured for a long time, it's preterm rupture of membranes, or if that patient is GBS positive, because we know that she has an active high level of bacteria in her vaginal canal. So we want to try and limit the amount of exams for that patient as well. But yeah, no, that's a really good question.
And
So
you wouldn't do it with placenta previa either, would you?
correct. No, you would not want to do that with placenta previa. You do not want to check a woman's cervix at all if she has a placenta previa. Why would we not want to do that?
That's your rupture.
Yeah, it can cause a rupture.
It has
Exactly.
oxygen.
Definitely. Yeah, that's awesome. So, yeah, if a patient's been ruptured for a long time, if she's been ruptured and she's preterm, if she's GBS positive, or if she has a placenta previa, we're going to want to question or be cautious or mindful about how often we're checking her cervix. Definitely.
I've never had a kid, so like when you said we as a nurse, we could go in, I knew we could do an exam, but like as far as moving the baby off the cord, I didn't know a nurse could do that.
We only have to do that if there's a cord prolapse. So
Okay.
sometimes, like, it's really hard to feel if the water is intact, like where the cord is, just because the umbilical cord is soft and it feels a lot like the membranes that are surrounding the baby. So it's really hard for a nurse when you go in and do an exam, to be able to differentiate between the two. But if her water breaks and that cord falls out, you're going to turn her, reposition her so that she's either in like a knees to chest position or Trendelenburg, to get pressure off that cord. And then you're going to go up and you're going to relieve pressure yourself. And every time that there's been a cord prolapse that I've been a part of, that nurse that has their hand in, who's the presenting part, she is she is like that basically until they have that patient draped and they make an incision to get that baby out. So she goes back on the bed with the patient, like you're not moving your hand out once it's in.
Okay.
Yeah, it's a pretty big emergency. So
Thank you. That makes sense.
those are awesome questions. All right. Late decelerations. So, one of the things that we need to know is what is abnormal versus what is normal. Okay. So, I don't know, at least in my class, I was teaching when we were going over fetal heart rate and stuff, I was teaching veal chop mine as a mnemonic for you guys to remember like what the deceleration is, what is causing it, and if it's okay or not, or what our interventions are. So, with a late deceleration, what is causing a late decel?
Placenta perfusion problems.
Yeah, we're not oxygenating that baby. We're having some issues perfusing our placenta. So late decels are the ones that we're really worried about, and those are the ones that happen after the contraction, right? Early decelerations are okay because an early deceleration is head compression, and it's okay if the baby's head gets squeezed. We really care about whether or not they're being oxygenated, okay? So with a late deceleration, we know that baby is not getting good oxygen. So if you're actively giving a patient medication to increase their contractions, to strengthen their contractions, and that baby is having a hard time oxygenating specifically with the contractions, we need to stop the contractions. That's what's going to help. Okay, so we're going to turn our oxytocin infusion off because that pitocin is giving that patient more contractions, causing more fetal distress, and we don't want that. So the first intervention that we need to do is stop that oxytocin. Okay. Um, Fatigue in labor is normal, so we're not going to be too worried about that, and that's not really an emergency to decrease or turn off our pit. We would turn off our pit if a patient loses consciousness. That's a whole different scenario, right? Drowsiness, it's okay for a woman to be really sleepy in her labor. She's probably been awake, she's been in pain, she's been laboring. That is okay. If it said something like altered mental status or decreased consciousness or something like that, then of course we're turning our pit off, and that is a whole nother scenario. But for this, if we see late D cells, that is indicating that our baby is not having enough oxygen, our placenta is not being perfused, and we need to stop our contractions. Okay? So instead of thinking about Pitocin, I think it's sometimes hard when we're thinking about PIT. Instead of thinking of it as a medication, think of it as like your contractions. Okay? Because Pitocin, what it does is it gives contractions. So if you have oxytocin, you're going to have contractions. Okay? So if we have something bad that's on our fetal heart rate tracing, we need to stop our contractions because that's whenever we see that baby's heart rate decrease. Okay? Being affected by Rh incompatibility. Yes. So with RhoGAM, it's not going to change the Rh factor in a baby's blood for the next baby. Basically, what it's going to do is prevent that baby or that mom from developing antibodies to the baby's blood and for attacking the fetal cells. Okay. Rubella infection is prevented by the MMR vaccine. So just knowing you guys what RhoGAM does, what the immunoglobulin is supposed to do, and then the differences in the blood incompatibilities, okay, for your exam. That's going to be helpful. So if we see fetal tachycardia, we are going to be worried about maternal infection. So let's take away fetus versus mom versus whatever versus OB. If you have a patient and you're at the bedside with a patient and a patient comes in and they have a heart rate of like 155, okay? What is something that you're going to want to check right away? Like, we're worried about them having some type of infection too, right? We're not thinking about SVT. We're not doing the 12 lead EKGs right now. Just like your most simple assessment tool, if a patient presents with tachycardia, we're going to rule out if they have an infection, right? So that is the same thing in utero. If you see a baby that spikes up to over 180 or over like 160, we should be worried that that mom is developing some type of infection. Okay. Gestational hypertension is more likely affecting the placenta, right? So gestational hypertension is causing that constriction, which is ultimately going to reduce our blood flow to our placenta. So if there's a gestational hypertensive patient, we're more likely to see a baby's heart rate have decelerations or drop because the placenta is not being as adequately perfused. Okay, so anytime you see fetal tachycardia, you should immediately be worried about infection. Okay. Does anyone have questions specifically about that?
I don't, but I do have a question about the last one, the RH and the RhoGAM. Will you explain that one more time?
Yes. So Rh immunoglobulin is going to be given in a pregnancy to help prevent moms from developing antibodies to subsequent pregnancies. Okay. It's not going to change like the fetal, what the baby's blood type is going to be. It's not going to change mom's blood type. Nothing is going to be changed, or the Rh factor. Okay. It's basically going to help prevent moms from miscarrying or from developing antibodies against the fetus and by attacking those fetal cells.
Thank you.
Yeah. I know, at least like for my class, I have like a whole slide that I usually show that goes into the different like RHO incompatibilities. Because there's a couple ABO incompatibility, all of that. So, I think there's a really good, I forget what page it is in the textbook. I wish I had my PowerPoint pulled up. But there's like a whole chart that goes through each thing, and then it talks about RhoGAM as well, and then the Rh immunoglobulin. So I would definitely check that out in your textbook, because I think that it's really helpful to be able to see all the three different kinds that we talk about a lot in this class all together. All right, last question here. Okay, so what is something that we're really worried about with ectopics? Like our number one concern with an ectopic pregnancy?
Hemorrhaging,
Yes, why?
because it can rupture the fallopian tube.
Exactly. Yep. So with an ectopic pregnancy, what's so dangerous about it is a fertilized ovum that is implanted somewhere that is not the uterus or the endometrial lining. Okay. So this is really dangerous because if this pregnancy is progressing and this is growing and it's growing in a fallopian tube, it could potentially rupture that fallopian tube because it's just getting too big, right? So if we have a patient that is at a high risk for a hemorrhage or is a high risk for, being hemodynamically unstable, we need to monitor their pulse and their blood pressure, right? Because if they're bleeding, what is their blood pressure going to do? Their blood
Decrease.
pressure, yeah, it's going to drop. Their blood pressure is going to drop drastically, okay? And what would their pulse do?
Increase.
Yeah, their pulse is going to increase. So if you see those two things and those two indicators, and then she's also bleeding on top of it, we are really concerned about that. So we need to monitor these patients' vital signs very closely, okay? Um, Signs of infection is not a terrible choice, but with ectopic pregnancies, our number one question or our number one concern is that fallopian tube rupturing and causing that mom to bleed. Sometimes, if a fallopian tube ruptures, well, most of the time, all the time, a patient has to be rushed back to the OR. They potentially run the risk of losing not only that fallopian tube, but potentially the entire uterus if they can't get that bleeding to stop. Okay, so that's why an ectopic pregnancy is something that we manage so closely because it can be quite emergent. Okay, that I think concludes our Kahoot game. So I want to take the time now to go over things that individually that you guys may have some extra questions or concerns on as you're studying for your exam. If there were things that you just don't understand as well, or there were things that you wanted to have clarified. We can also run through really quick. Um, some terms that I think are going to be really important for you guys all to understand. So like if you guys want to write these down just so that you know them, Definitely know hyperemesis gravidarium, the difference between that versus just normal nausea and vomiting in pregnancy. Okay, know your different stages of lochia, what each of them mean, and what they could indicate, what it could indicate if a patient starts having like rubra again, like 6 weeks postpartum. Okay. We know that we need to know our differences between a placental abruption and a placenta previa. Understand the differences between postpartum depression versus what is postpartum psychosis. That's a big one. Understand what preterm labor is, as well as premature rupture of membranes. And then know like what an episiotomy is, why we cut episiotomies, what they are beneficial for. And then like also understand and know what a post-term pregnancy is and what are some common concerns or things that we may see with a post-term pregnancy. I think that all of those topics are going to be like really good for you guys to definitely spend a little bit more time on and reviewing. Um, in addition to the other like big points that we've been going over, like you guys have been going over in class, but I think that that is a little bit more of a condensed, like definitely look into those types of things.
Miss Dr. Young, I have a question.
Yeah.
So it's dystocia. Is
Mhm.
it the clavicle that is being that you have a fracture, the baby have a fractured clavicle or a humerus?
So it would be a fractured clavicle for a
Okay.
shoulder dystocia. What can
Okay.
be confusing when you guys are studying for exam two is that the term dystocia just means dysfunctional. Okay. And that is where it gets confusing with OB terminology because like we use different words or the same words in different all over the place. Okay. So dystocia, when we're talking about labor, is a dysfunctional labor. A shoulder dystocia is what happens when that baby's shoulder gets stuck under the mom's pubic bone during delivery. And that is an emergency and we need to do our maneuvers, right? So
Okay.
definitely know the maneuvers associated with each one of those.
Okay.
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 Um, and then like what puts a patient at risk or high risk for a shoulder dystocia?
Macroscopic baby.
A macrosomic
A big
baby.
baby.
Yeah, a big baby. So what patients do we see big babies with?
Diabetes.
Gestational diabetes.
Yeah, a gestational diabetic is going to have a risk for an a big baby. A post-term pregnancy is going to have an increased risk for a macrosomic infant.
Okay.
Okay, so all of these patients we need to have in the back of our mind, okay, they have a high risk for shoulder dystocia. Shoulder dystocia, the biggest risk with that for the baby, besides decreased oxygenation and the risk for metabolic acidosis, is a fractured clavicle. Okay.
Okay.
Which we talk about that way more extensively for exam 3 content whenever we talk about newborn assessment. For this exam, we're mostly focused on like labor dystocia, things that can happen during labor, right? So that would be one of them. So for this, the purpose of this exam, I want you guys definitely to know your McRoberts maneuver, you understand suprapubic pressure, what you're going to do as a bedside nurse if your patient presents with a shoulder dystocia.
Okay. All right. Let me write some questions down.
So going back to the lochia, you said we need 6 weeks post-op, and if it goes back to lochia rubra, we need to know the reason. Is that correct?
So mostly I was kind of using that as an example. So like if you when you're doing your studying, know the 3 different phases, know when you should be seeing them in a like relation to how far postpartum a patient is. And then know like what could that mean if a patient is in this stage but she's now having bright red bleeding again. Like, are we worried about endometritis? Are we worried that this patient has an infection or that there's something that, like, maybe she had incisions and her incision site is, her stitches popped, because that can happen and it's pretty gnarly. So, kind of being able to use that thought of, okay, this patient's 6 weeks postpartum, this is what her lochia should look like. They're saying that she's having this presentation when she comes into the ER. What could this mean? Okay. I would definitely also on your guys' list put down, the differences in knowing the clinical signs and symptoms between a UTI, mastitis, endometritis, and a surgical site infection or a perineal laceration infection. Being able to differentiate between those four things, those four common postpartum complications, I think will be really helpful for you as well.
You
What
said
was the last one?
UTI. Oh, I'm sorry. You said UTI, mastitis, laceration, and what else?
Endometritis, the infection of the endometrium. What other questions do you guys have? And if you guys can't think of anything specific right now, you guys should have access to my email address. I will be posting this recording too, as will all of your professors in your shells, so that you'll have access to it. But if you guys need to reach out and ask me follow-up questions or there's anything you wanted clarified, don't hesitate to reach out, okay? Sorry, my dog's like, they just got back from a walk. They're really excited. But does anyone have anything else right now? I do have a meeting with a student here shortly, so I was going to probably hop off here soon. But if anyone has had something, we could talk about it last for just a couple more minutes.
Thank you for your time.
Okay, well, yeah, just don't hesitate to reach out if you guys think of anything. Like I said, we'll be posting all these recordings so you'll have access to them, okay?
Thank you.
Great. Thank you so
Thank you.
much.